Hi, I'm Ken Currington. I'm one of the surgical educators here at Campbell's, and today I'm going to demonstrate for you the use of the Glidescope in performing endotracheal intubation. Now, of course, we can use direct laryngoscopy to perform endotracheal intubation, but as you will soon see, this is an extremely valuable technology that has now made intubation much easier, much safer, and in most cases this is considered the gold standard technique. So we now have a patient who, for whatever reason, needs a definitive airway, and we're going to use a Glidescope. Let's talk a little bit of anatomy first so that we can understand what we're seeing. This is a representation of the oral pharynx and the larynx. If the patient is lying in the supine position, such as the mannequin here, we can see that his lower incisors are directed anteriorly and inferiorly, his tongue directly from posteriorly to anteriorly, and then the larynx, of course, is going to be very posterior, with the esophageal entrance the most posterior structure. This is the base of the tongue, and you can see that there is a small recess here between the base of the tongue and this floppy cartilaginous structure. This is the epiglottis, which, as you know, closes over the entrance to the larynx during swallowing to protect the airway. This recess is called the vallecula. That's a V, vallecula with the V. You can see that there are small folds that begin at the lateral edges of the epiglottis and then proceed to a V, i.e. they meet in the posterior midline. Those are called the airy epiglottic folds. Those small bumps that you see on top of the airy epiglottic folds are formed by the arytenoid cartilages. The arytenoid cartilages are small piston-like cartilages that sit on top of the cricoid cartilage. They rotate, they're attached to the vocal cords, and they are what allow the cords to open and close during phonation and breathing. And then if you look straight down, you can see the cords represented in the mid-larynx. All right, so this is the anatomy that we're looking for when we are performing either direct or videoscopic laryngoscopy. One other thing I will say before we do this, let's look at the different types of laryngoscope blades and how they relate to this particular anatomy. This is a Macintosh blade. This is for a direct laryngoscope. Notice, if you're not sure, it'll say Mac, and it'll actually give the size at the base of the blade. These are easy to remember. Mac has a C, so a curved blade. This is designed actually during direct laryngoscopy to come in at the base of the tongue and to fit in the vallecula, and then with pressure upward and anteriorly, which is what we should be doing, not against the teeth, it lifts the epiglottis up so that we can see down the larynx. If, and we often see this, we have a floppy epiglottis that tends to stay covering the entrance to the larynx, even though we are in the correct location with our Mac blade, we can use the Miller blade. And again, Miller, a 4 is a standard size for an adult. They come in a variety of sizes as you can imagine. Miller has 2 L's, so double long and straight, easy to remember. This blade is actually used to come in and grab the epiglottis itself, or actually to lift the epiglottis up so that now you can see fully the entrance to the larynx. The Miller blade. Okay, let's look at our videoscope blade. This is the Glidescope. It has, as you can see, a prefabricated curved blade closely resembling the Macintosh. The first thing we need to do is make sure this works. You can see in this case, this Glidescope is attached by an electrical cord to the outlet. It also has a battery backup. You have to turn it on, pretty easy to do. Gray button, on button, simply hold it until it comes on, and then the scope runs through its warm-up. Now you can see that I have a light on the scope, which is very important. If the light doesn't work, you will not be able to see, and the camera's not working. You can see my hand. You can see my videographer. You can see the patient. Okay, now the scope is ready to use. We're going to set it aside now to prepare for the rest of our procedure. Preparation, as in all things procedural, is very important. We do not want to advance a device into a body cavity or a blood vessel or any part of a human being without having everything that we need available and easily within reach to complete our procedure. So what are we going to need in this case? First thing is an endotracheal tube. This is a standard endotracheal tube. They come in different sizes and are made by different companies. This is a microcuff. Notice it says ID 7.0, OD 9.3. That's pretty straightforward. The internal diameter of the tube is about 7 millimeters. The outside diameter is another 2.3 millimeters added on, which is the thickness of the material, so 9.3 millimeters. Notice there are tick marks with centimeter markings. These detect the distance from the tick mark to the end of the tube. Very important because we use these tick marks as an indicator as to whether or not our tube has been advanced or withdrawn over time. I usually have the ICU nurses mark on the chart the correct tick mark location of the tube with respect to the upper incisors. That way, if I came in the next day and I saw it was too far down or not far enough back, it would be indicated by the tick mark change. This is an insufflation balloon with an indicator, or an insufflation port with an indicator balloon. This is the actual cuff balloon. These are, in most cases, a high volume, low pressure cuff. They take somewhere between 10 and 20 cc's of air. That will be indicated on the package in which the tube comes. I engage a syringe with the valve. You can see the white valve did push down when I advanced the syringe, and then I check the balloon. Notice how I use the syringe. I use my thumb on the plunger and my index finger and my middle finger on the phalanges. That gives me perfect control. You can see the balloon now completely insufflated. It's actually easily pressable. This is the purpose of a high volume, low pressure tube or cuff. It provides minimal pressure on the tracheal mucosa and minimizes the risk of ischemia. So in this case, I'm going to re-deflate the balloon because I want to be able to put this into the patient. I want to make sure it is completely deflated. So I'll do the double syringe aspiration. You can see that that is now completely collapsed. I will pull this back to the maximum volume that I can put in so that I can be ready to blow up this balloon once I put it in the larynx. You can see the syringe now engaging the white valve. Very important that you have the appropriate adapter on the end of the tube so that an ambu bag will be able to be attached to the endotracheal tube upon completion. If you don't have this, you will not be able to ventilate the patient. And I have seen these come where this was not attached. So you need to make sure that everything that you need is ready. In adults, we insert endotracheal tubes with a stylet, and because we're using the Glidescope, it has its own special stylet. The stylet has a blue plastic handle. This is a much more rigid metal than we normally see with stylets that are used for direct laryngoscopy. That's because we want a particular orientation or curve to this tube. That facilitates the advancement of the tube into the larynx. Notice, forms a little bit sharper J than we normally would use with direct laryngoscopy. Also, very important, this black mark is the it's the laryngeal vocal cord indicator. In this case, one of the things that is very common among young intubators is you get it in the trachea, you get excited, and you advance it too far. All you need to do is get the balloon below the cords. This indicator is meant to help you identify the cord level so that the balloon now is not advanced too far and you don't get a right main stem intubation. Now this tube is ready to go. It has a stylet and it has a syringe. Notice, very important, we do not want the stylet to go beyond the end of the tube. If it does, it could create tracheal mucosal trauma as it's advanced, bleeding, and obstruct our airway. I lay the tube to the right side of the patient, oriented inward. so that I can literally reach down without looking at the patient or the tube, grab the tube, and I'm ready to go in the correct orientation into the larynx. What else do I need? Well, we pointed out an ambu bag. Obviously, I need to be able to ventilate the patient upon completion. Very important. A Yankauer suction tip attached to a working suction so that I can clear the patient's mouth of blood, mucus, debris, teeth, whatever is in the way that is preventing me from seeing the larynx. What happens also if I try to insert this and the patient has a gag reflex and vomits, I can potentially prevent aspiration if I'm quick draw on my suction. So suction is critical, whether you're using direct or videoscopic laryngoscopy. Finally, I want a way to secure the tube. You'll find anesthesiologists and emergency room physicians who do frequent intubation have their own ways. Often they'll want a tape. That's fine. If you're going to use tape, you want to have it cut and easily accessible after the tube is in so that you can quickly secure the tube. This is a commercially available endotracheal tube secure device. It's very nice. Usually I have this set up before I even put the endotracheal tube in. It has a phalange that goes underneath the patient's neck. So I'll literally have it waiting right like this so that I can attach it to the tube once I'm intubated. All right, now my patient is unconscious. I have preceded my intubation by giving him bag valve mask ventilations to maximize his oxygen saturation. Now I'm ready to try to intubate. My scope is on. I'm going to hold, as in all things laryngoscopy, the scope in my left hand. Intubation is never a right-handed procedure. Sorry, you right-handed people. I'm a lefty, so this works great for me. Anyway, we hold the tube in our left hand, and I'll get the cord out of the way. Make sure you're not holding it upside down. Proper orientation. Now I want to open the patient's mouth. We've talked about this before, the snap finger technique, in which I snap my fingers, use my thumb on the bottom incisors, my middle finger on the top incisors, and I can easily open the patient's mouth. Now, carefully advancing the scope so that I don't catch the back of the tongue. So see how I have the scope pointing straight posteriorly? I go into the larynx, and it's better to go in too little than too far. And this applies to both direct and videoscopic laryngoscopy. So I put in, there's the uvula. You can see the palatoglossal and palatopharyngeal folds with the tonsils. There's the base of the tongue. Now, I no longer need my right hand because I'm using the scope to see the larynx. So I'll reach down with my right hand now and grab the endotracheal tube. Notice I just reach down, I don't even have to look. Grab it, and I grab it halfway down the length of the tube. Now, I'm just going to march this down. Oh, there we go.
No,
epiglottis.
This is tongue.
Base of tongue.
Base of tongue right there.
Right. And epiglottis. Now,
Epiglottis here.
Right. Now, Dr. Sloan, if you'll walk around to the right side and you can see where my scope is, you can see it is not touching the teeth. And this would be the same case if I were doing direct laryngoscopy. Common mistake, we've all done it, pulling up against the teeth. And that's why we have a clicker. When I'm teaching this to groups, and if I start here clicking, I start running and seeing who's going to pay for the broken teeth. Notice, I can see just fine without lifting up on the teeth. So I march down until I get the blade in the vallecula. And quite frankly, that's all the visualization I need. If you get too close, there's not enough room to manipulate the scope to have it go into the larynx. So a common mistake is to get right down here on top of the larynx. You want to just intubate the vallecula. That's really all you need. Now, notice the tube follows the hard palate, goes in, and literally falls right into the larynx.
Do that again, Ken, and I'm going to show it on the video here.
Okay, so I advance, I'm following the curve of the hard palate, go in, and I'll get a little better visualization. And notice it just falls right in. Notice there's my black vocal cord mark. So where do I go? Until the black mark reaches the vocal cords. Now I'm intubated.
And Ken, I'm going to have you do it one more time, and I'm going to get a close-up here of the tube going down.
All right, one more time. And again, that's about the right distance. I can clearly see everything. Vallecula, epiglottis, ariepiglottic folds, right? Follow the hard palate, go in, and it just falls right in. And I advance until the black line is up against the cords, at the cord level. Now, I no longer need my videoscope. It does not add anything further. It's done its job. Carefully comes out, and in this case, to prevent it from being damaged, I'm just going to put it back in the holster. Notice, my right hand now does not come off the endotracheal tube. As soon as you intubate and you go, oh, I'm done, and you start reaching for other devices, the patient coughs, the tube comes out, and you do it all over again. So my hand, my right hand, I don't switch from my left hand. My right hand stays in this position until the tube is secured. I've intubated. I've got a thumb and index finger on the tube. I'm resting it on the patient's face. Now I'm going to have to breathe the patient, right? Can't breathe with a stylet in, so I like to just get the obstruction out first. I grab the stylet and I simply follow the curve of the stylet as I pull it out. If you pull the stylet straight out, you will pull the tube up against the anterior wall of the trachea, meet resistance, and potentially cause damage. It's very common. You're excited, you've intubated, you jerk things out. Take your time, pull it out. Now I've got to blow the balloon up. And what I like to do, instead of reaching across, is I reach underneath my right hand and I easily grab the syringe. I put it in the correct orientation, index finger, middle finger on the phalanges, right? Thumb on the balloon, plunger. Sorry, thumb on the plunger. Blow it up. My thumb does not come off the plunger. Why? Look what happens if it does. While I'm reaching to do things, the plunger automatically comes back. I lose insufflation. Now I no longer have a secured airway. I'm not able to ventilate as well, and I run the risk of aspiration. So, finger does not come off the plunger, thumb does not come off the plunger until the syringe is detached and the valve is released. So look, hard to do it like this. I simply roll my fingers underneath, create a claw with my third, fourth, and fifth fingers, grasp, twist, done. Notice my right hand is still on the patient's face. Now at this point, I want to see if the patient can be ventilated. I have my ambu bag ready to go. I attach it to the endotracheal tube, insufflate. And you can see that fortunately I got in. It would be pretty embarrassing if I didn't. There we go. Now, let's talk about ways to confirm endotracheal intubation. Remember, we're doctors, so we get to do physical examination, inspection, bilateral equal chest rise, auscultation, bilateral equal breath sounds. We can use a little technology and use a capnography. If we have it, we can attach it to the endotracheal tube and to our monitor and get a capnogram. Or we can use a qualitative capnogram. And if you look very closely, you can see that the lowest concentration is purple and the highest concentration is yellow. That indicates CO2. So I can put this in series with my tube. Notice my right hand is still here because I haven't secured the tube yet. Everything is done with my left hand, right? Hook this up, and what I would like to see is that the color stays yellow. That means I have CO2 returning. The stomach doesn't have CO2, only the lungs. So now I have confirmed in 3 ways that the endotracheal tube is in the correct location. Cyanosis, or purple is bad, that would mean I intubated the esophagus. Now, hopefully I have some help. I can hold this while my colleagues either tape or secure the tube with this particular device. What's the final thing that we need to do to confirm correct location? Chest x-ray. So, a lot of the principles I've showed you today apply to direct as well as videoscopic laryngoscopy. But this is now the gold standard, and I hope you will all have a chance to use the Glidescope at some point in your career. It is a wonderful tool. video laryngoscopy.
Thank you.